We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Eclampsia and PPH, organized by Pinnacle News Series in association with Mancherial, Kolhapur, Jalgaon, Aizawl and Solapur OBGYN societies. So let us start the webinar with Saraswati Vandana. Lightning of lamp. It's my privilege to introduce the embassy of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the consultant and obstetrics and gynecology and reproductive medicine in Salem and national coordinator of Midlife Management Committee, FOXY. I welcome you, ma'am, and I hand over the session.
Thank you so much, Sahati. I invite you all faculty and delegates to this very unique Pinnacle webinar series, which includes society from all parts of India. This is organized by none other than Professor Dr. Sampath Kumari ma'am. It is my privilege to introduce Dr. Sampath Kumari ma'am, who is the professor and HOD at Sri Muthukumaran Medical College and Research Institute at Chennai. She is a past vice president of FOXY. She is the current Senate member of Tamil Nadu Dr. MGR Medical University, and she's also the national corresponding editor of JOGI, founder secretary of Tamil Nadu Federation of Obstetrics and Gynecology. She's the current president of OXY. She is also the past retired director of Institute of Obstetrics and Gynecology, Madras Medical College at Chennai, and she's the president of Board of Studies of OG at Tamil Nadu Dr. MGR Medical University. She is a past chairperson of FOXY Adolescent Health Committee, and she received the first ICOG Distinguished General Council Member Award. And she's also the chairperson of Women's Wing IMA Chennai South, and she also received the prestigious IMA National President's Award and IMA Tamil Nadu State Branch Award. Over to you, ma'am. Ma'am, you're muted, ma'am. Ma'am, you're muted.
Good evening to all. Thank you, Dr. Madhumita. I welcome you all for this Pinnacle series. Here we take societies from North, East, West and South. That is, it is called as Pinnacle News. This time we have included the societies of Mancherial, Kolhapur, Jalgaon, Aizawl and Solapur. I welcome Mancherial Society President Dr. Nalmas and the Secretary Dr. Aliveni, and Kolhapur Society President Dr. Manishi and the Secretary Dr. Ranjita, Jalgaon Society President Dr. Vaishali and Secretary Dr. Anita, and Aizawl Society President Dr. Lal Ram and Secretary Dr. Sid Sangliana, and Solapur Society President Dr. Sujata and Secretary Dr. Joshi. Now we have two sessions, one session being the talk on eclampsia and the other session being the panel on PPH. We have wonderful panelists, Dr. Meena Mahalingam, moderator Meena Mahalingam and Suhasini, and the panelists being Dr. Pratibha, Dr. Jyoti, Dr. Tangamani, Dr. Swati, Dr. Ketki, and Dr. Ashwini. And I welcome you all for this interesting Pinnacle and academic series. Now we will go with the felicitation. First, I call upon the President of the Solapur, Dr. Sujata, to tell few words about the webinar. Dr. Sujata. Dr. Sujata is the president of Solapur Society. Sujata, you are muted.
Sujata ma'am, you're muted now.
Yeah, hello. Good evening, everyone.
1 minute. Sujata, CV.
Sujata.
Dr. Sujata is from recipient of first late Dr. Leela Dubai Gold Medal, and she has worked as medical officer in Solapur Mahanagar Palika for 8 years, and Ramakrishna Hospital for 7 years, past VP of SOAPS, and past Honorable Secretary and Clinical Secretary of SOAPS and EC member. Her area of interest is female infertility and adolescent health. Yes, Dr. Sujata.
Yes, good evening, madam, and good evening, everyone. First of all, I would like to thank for giving our society this opportunity. And the topics are very interesting and for our day-to-day use like eclampsia and PPH. And we give best wishes from our society for this news, Pinnacle news series. And thank you so much. Looking forward for your informative lecture on eclampsia and a wonderful panel on PPH. Thank you so much.
Thank you, Dr. Sujata. Now I welcome Dr. Vaishali. Dr. Vaishali is the president of Jalhan OBGN Society. Dr. Vaishali, few words, you are muted. Yes, Dr. Vaishali, welcome.
Yes, madam. Thank you, madam, for inviting us for this webinar. Being eclampsia and postpartum hemorrhage are being the leading cause of maternal death. So this webinar will help everybody to tackle with all these cases. Thank you for inviting us. Thank you again.
Thank you, Dr. Vaishali. Now we have Dr. Ranjit. He is from Kolhapur Society. Dr. Ranjit is a consultant in Kolhapur, Maharashtra, and General Secretary post in Kolhapur Society, and worked as AS Treasurer in the same society, and holding co-chairman and organizing secretary in many conferences, conducted Sexology Conclaves 2025 Amok State Conference in December 2025, and awards Dhyan Jyoti Puraskar in 2025 and Amok's Appreciation Award. Dr. Ranjit, welcome, and few words. Dr. Ranjit.
Thank you, madam. And you are doing a very good and great job. These are the day-to-day topics, and we are very much interested in it. And thanks a lot. And go ahead. I think before introduction, we'll start it immediately. Okay, so that will not waste time.
Thank you. Thank you, Dr. Ranjit. I think AISWAL and Mancherial Society President or Secretary is not there. We will go to the scientific session.
Sridevi ma'am has joined, ma'am. Mancherial President has joined, ma'am. Dr. Sridevi has joined.
Yeah, yes, welcome, Dr. Sridevi. CV, please. Dr. Nalma Sridevi. She is the President of Mancherial OBGN Society. And Dr. Sridevi.
Sridevi ma'am, you're muted, ma'am.
Dr. Sridevi, are you there? Please unmute. Day before yesterday, I was talking to her. She is not able to unmute, I think.
Sahiti, can you unmute, ma'am?
Yes, ma'am. I have requested from my end.
Okay.
Sridevi, ma'am.
I couldn't see her.
Yes, ma'am. Ma'am has just got disconnected, ma'am.
Okay. Okay, moving on to
Yes,
moving on to the scientific session. It is my privilege to introduce the chairperson for this first session, Dr. Sujata Kulkarni.
Hello, ma'am.
Hi, ma'am was just introduced. She's the president of Solapur Obstetric and Gynecological Society, and she's also the past vice president of SOGS, past ordinary secretary and clinical secretary of SOGS, and past executive member. And she has her areas of interest of female infertility, adolescent health, and public awareness. Over to you, ma'am, to introduce Sampath, ma'am.
Yeah. Once again, good evening, one and all. Actually, we have very nicely introduced Sampath Kumari, madam. So previously, so it's like privilege to introduce madam. Looking at her CV, we can tell that madam is a professor and head of the department of obstetrics and gynecology at Sri Muthukumaran Medical College Hospital and Research Institute. She was the past vice president of the FOXY, Senate member, Dr. MGR Medical University. She is a national corresponding editor of Jogi, founder secretary, Tamil Nadu Federation OBGY, president of, I think it's Obstetrics and Gynecology South Indian Societies, right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes, Dr.
Yeah,
Sujata.
because
Yes.
this is something new for us that it is such a prestigious post, madam, actually, and I think you were the for all the South Indian societies. I mean, that is really great. She was the
No, first
director
it was
institute
the
of.
only one society before Foxy. It is the only
Okay.
one society and it was named as Southern India. Then from this only Mumbai society went and the Foxy formed an or federation. We were
Acha,
more,
okay.
now it is again Tamil Nadu, Kerala, Karnataka, 5 states are there. In Tamil Nadu itself, 21 society. But it is when our people, they don't want to change the name. So it is that. At present, I am the
Okay.
president of Chennai Society.
Acha, okay. So for us, you are the president of
Yes, thank
South
you.
Indian,
Thank you.
because I saw what it is actually exactly. Okay, got it. She was the director Institute of OBGY, MMC Chennai, President Board of Studies OBGY, TN Dr. MGR Medical University for the year 2015-19, Chairperson Foxy Adolescent Health Committee, first ICUG Distinguished GS Member Awardee in 2021, Chairperson Women's Wing IMA Chennai South, and recipient of the IMA National President Award and IMA TNSB Award 2021. And
Thank
Madam is going to, yes, your topic is eclampsia. We want to know what are the newer things in eclampsia, and over to you, Madam.
Thank you. Thank you, Dr. Sujata. Now we will go with the... Yes. Everyone can see, I think.
Yes,
Madhumita?
madam, we can see.
Yes,
Yes,
ma'am.
Madam, we
Yes,
can
ma'am.
see.
So eclampsia, as first we'll go with what is the hypertensive disorder. Then finally we can go with the eclampsia. Hypertensive disorder, as all of us know, this is when the BP is increased after 20 weeks of gestation. It is called as hypertensive disorder in pregnancy. Previously, 3 points were taken into consideration. One is edema, second is proteinuria, and third is the increased BP. Now this edema is common in all the patients. So it is a dependent edema, we don't take into consideration. And the proteinuria is also present only in pre-eclampsia. Even in the urinary tract infection, we can have the proteinuria. That is the reason now it is also not considered only the elevated BP. When only BP is elevated, it is called as gestational hypertension. As for the classification, hypertension ISSHP, it is less than 20 weeks and more than 20 weeks. This 20 weeks is again divided into less than 20 weeks is when a known hypertensive patient becoming pregnant is chronic hypertension. That is the chronic hypertension, white coat hypertension. Once the patient gets the VP whenever she comes to the OP, and the masked hypertension. Previously it would have been there, now it would have been marked there. Again, this chronic hypertension is divided into essential hypertension and the secondary hypertension. And the BP increased after 20 weeks is considered as gestational hypertension, transient gestational hypertension, and pre-eclampsia. Pre-eclampsia is again, now it is mild and severe. It can be the de novo or superimposed. That is, even the chronic hypertension can be superimposed with the pre-eclampsia. But for our convenience, the classification is only this. That is 20 weeks. Before 20 weeks, if BP is increased, That is the chronic hypertension. If after 20 weeks, if it is increased, it is called as gestational hypertension, where there is no proteinuria. Preeclampsia, where proteinuria may or may not be present, that is called as mild or severe preeclampsia. And then comes the eclampsia. So this is the eclampsia. If any two of these superimposed with chronic hypertension, it is called as the superimposed preeclampsia. Again, the eclampsia can be superimposed with the gestational hypertension. So this is the simple classification we are calculating. So as all of us know, the pathology is abnormal placentation. That is the abnormal trophoblast development, spiral blood flow, placental ischemia, and hypoxia. So there is an angiogenic imbalance and endothelial dysfunction, which leads to the systemic dysfunction, and that produces the preeclampsia. The pro-angiogenesis and anti-inflammation factors being PAGF and VEGF. This anti-angiogenesis, pro-inflammation, endothelial dysfunction is being SFLT and the S-engine. This SFLT and the PAGF, EEGF are the predictors, which is done in the well-developed corporate set of hospitals. So when the BP is increased, we consider them as the chronic as the gestational hypertension after 20 weeks. Once the patient is on gestational hypertension, we have to ask these 5 symptoms. That is the imminent signs we tell. The vasoconstriction, headache, blurring of vision, upper abdominal pain can be HELLP syndrome, and the urinary output, if it is reduced. And finally, we will ask about the fetal movement. If any of this is present, we can think that the patient is going for the preeclampsia. Preeclampsia, if all these things are present, it is severe preeclampsia. If none is present, only the BP is increased 160 by 110, means it is mild preeclampsia. If you don't identify the patient in the preeclampsia, then comes the eclampsia. See, among this hypertensive disorder in pregnancy, 8 to 10% it is present in the complications of the hypertension. This preeclampsia, among this hypertension, preeclampsia is 3 to 9% in the developed countries. So this is the prevalence. Again, this eclampsia in our state, that is in our country, India, it is 1.52. We have 2% of the pregnancies. And by the national registry, eclampsia registry, it is 1.9%. So 8 to 10% of all pregnancies can go for hypertensive disorder complicating pregnancy. And 3 to 9% can go for preeclampsia if not identified and treated. Even if you're not identified in this stage, again, 1.9%, that is 2%, can go for the eclampsia. Eclampsia is the dangerous condition when an antenatal patient with BP increased through fits, that is the convulsion, seizures. If it is present, she may come with giving the history of convulsions 2 times in the house, and she may develop convulsions under treatment in the hospitals. Some patient can go for unconsciousness after the fits, and some may be conscious. So this is the fits during antenatal hypertension is eclampsia. So the eclampsia is defined as the development of convulsions and unexplained coma during pregnancy and postpartum in patients with features of preeclampsia. So the eclamptic convulsion can be antepartum and intrapartum or postpartum. Always the postpartum convulsions is the worst prognosis. So antepartum and intrapartum we will be monitoring. Sometimes the postpartum will be unnoticed. The antepartum eclampsia, almost cases develop beyond 28 weeks. That is not before the 28 weeks, only after the 28 weeks. Postpartum eclampsia can occur within 48 hours of delivery, or sometimes beyond the 48 hours also then can happen. So in these cases, what happens? Mainly with the eclampsia, the complication is being the neurological evaluation. That is very, very important. Once the eclampsia has happened, means the other complications can happen. They can go for cerebral hemorrhage. And because of this, the placental abruption can occur. The placenta can get separated earlier. And there is a possibility of PPH in these cases. And in the baby, there is the possibility for UGR. That is the reason in hypertensive disorder in pregnancy, we go with the ultrasound with the Doppler after 28 weeks, every 4 weeks. Then cerebral edema, pleural effusion, pulmonary edema, all these complications can happen. Sometimes patient can go for the coma. These are all the complications that can happen with the eclampsia. So we cannot prevent hypertensive disorder. Which patient is going for hypertensive disorder, we don't know. Because the placental abnormality can happen to anywhere. Even we have the risk factors as elderly primary, multiple pregnancy, previous preeclampsia, but still we don't know which patient is going on. But we can prevent the complications if you monitor the BP, that is appropriate BP cuff and appropriate management of monitoring with the morning and evening, and asking about the preeclampsia signs. We can avoid the complications of severe preeclampsia and eclampsia, though PAH cannot be prevented. So if the patient comes with eclampsia, the main treatment always, most of the time we see the from the primary health centers, the VHNs will say, I have seen the patient continuously, madam, suddenly she developed a fits. So normally without the preeclamptic signs and without monitoring the BP, the eclampsia will never come. So the eclampsia, if the patient comes in, always call for help. If the patient in the OP means, if you don't have doctors, at least you call the VHNs and the staffs. Whoever is there, you call for the help. The treatment for eclampsia is always ABCD. That is airway. Keep the patient in the dark room, put her head on the left lateral position, and remove the always, if the fit is present means there will be secretions. Put the suction apparatus and lateral decubitus and remove the secretions in the mouth. Put the patient in lateral decubitus position and the oxygen. If needed, the saturation is less means give the oxygen. B comes the breathing. If the patient is not comfortable with the oxygen and the breathing means sometimes you may even also need tracheostomy for the patients. That's the reason we always admit the patient in the dark room, that are in the ICU, HDU or ICU, and always get the help of the anesthetist. Whenever the patient comes, once you put the clear the airway, that is the nasal pathway, give oxygen, put catheter, always put catheter and drain the urine, make the patient in the left lateral decubitus position, make the breathing comfortable, and give IV line. Always the IV line should be in the 2 lines. So one can start the treatment of the drugs, the other can take the blood for investigations. If the eclampsia patient is coming means already you will be having the basic test, a complete hemogram and VDRL, HbS antigen, HIV. These are all the routine tests which we do have in the first visit itself. Now we have to take the liver function test, the renal function test, coagulation test, and whatever needed for the hemolysis, that is the coagulopathy, platelets and other things are. So though the basic test is present, if you take the LFT and RFT and coagulopathy, now we can see the other whether the patient is going for any other complications. Already she is in the eclampsia state. Then you go with the drugs. What are all the drugs we are going to give? So this is the main treatment. As I told you earlier, do not leave the patient alone. Place the patient in left lateral position, airway, assess, maintain patency, breathing, protect airway, ventilate if required, if needed, tracheostomy. Also, circulation. During the circulation, take this blood, BG, CBC, platelets, clotting screen, KFT, LFT, uric acid, say urea creatinine, serum electrolytes. And these are all the things you have to monitor: pulse, BP, respiration, urinary output, level of consciousness, and the urine protein. These are all the things we have to monitor. Suppose if the BP, consider it as first you do this and stabilize the patient. Suppose the BP is 140/100 and the patient is not conscious, means put the Riles tube. Always put the Riles tube and give the antihypertensive. Labetalol is the treatment for hypertension during pregnancy. You start with 200 milligram BD or OD or TDS. Maximum of 1,100 milligram can be given. Suppose in this eclampsia patient, if the BP is more than 160/110 and the patient is not conscious, means you go with the IV labetalol. IV labetalol is 20 milligram IV. The bolus can be given. And then after 10 minutes, see the BP. If it is not reduced, double the dose, 40 milligram. And after 10 minutes, again you see the BP. And if it is not reduced, again double it to 80. Maximum of 220 milligram can be given. Once the BP is stabilized, that is 140/100 or 140/90, then put the Riles tube and monitor the BP with the labetalol and the nifedipine. So this patient, first you are controlling the BP first. Then you are going to treat the convulsions. In the all should be done simultaneously. That is the reason you give 2 IV line. One IV line, somebody can give the labetalol. The other IV line, you go with the fifth chart regimen, magnesium sulfate. Fifth chart regimen is, that is magnesium sulfate is given 4 gram 20% IV. And 50% 10 gram IM. So 4 gram 50%, each ampule of magnesium sulfate is 2 ml, 1 gram and 50%. So for IV, take 4 ampules in 20 ml syringe, mix with 12 ml of normal saline or distilled water, and give within 5 minutes. It is then you make it into a 20%. 50% is each ampule is, I told, 1 gram. So 5 ampules. That is the 5 gram in the right side buttocks and the left side buttocks. This is the loading dose. And then every 4 hours, once the loading dose is, now you have given the antihypertension, labetalol IV, and stabilized the BP. For convulsion, you have started the loading dose of the Pritchard regimen. Then now the patient is stabilized. After the stabilization, then we go to do the pervaginal examination. That we can come. Then this magnesium sulfate, even if you are going to deliver, it has to be continued every 4 hours, 5 gram magnesium sulfate in the alternate buttocks, and it has to be continued for 24 hours. In some hospitals, they go with the suspend regimen, where the 1 gram per hour, that is the 24 ampules are put in the infusion pump, and 1 gram per hour that infusion pump is adjusted, and it is given to avoid the IM injections. So this Pritchard regimen loading doses started, and now we have stabilized the patient. Then we have to see the what happened. I'm not able to move it. Anyway, so now we have stabilized the patient. Okay. In between the 4 hours, what we have to do is respiratory rate, knee jerk, and output has to be monitored. So if anyone is less, means you can skip the dose and continue the in the next 4 hours. You continue the serum magnesium. Normally we don't examine. Normally it will not be magnesium toxicity will not be there. If at all present, depending on the value, the symptoms will be present. You can go with the calcium gluconate as the antidote. So delivery, now the patient, now you have stabilized the patient, then do the pervaginal examination. And if you see the patient is in labor, that is 3 centimeter or 4 centimeter, and the patient is comfortable, means you can go for the normal delivery. If it is closed and the patient is, baby is also 2.1, that is after the 36 weeks, means don't hesitate to do the LSES. In the emergency situations such as eclampsia, health syndrome, pre-eclampsia, it is better to go with the LSES rather than trying for the normal delivery and going for the complications. And so eclampsia dictates delivery once the condition is stabilized, irrespective of the fetal conditions, whether it is less than 28 weeks or 32 weeks or 36 weeks, whatever it is, in these cases, we have to terminate the delivery. There is no place for prolongation of the pregnancy unless there is no rare situations and all. In eclampsia, you have to deliver. So this is the way we are going to monitor. So now other patients, other than eclampsia, normally hypertensive disorder, if it is under control, means you can wait till the term. That is 36 to 37 to 38 weeks, you can wait. And if the patient is having pre-eclampsia or eclampsia before 24 weeks, means that is not at all a question. You are going to terminate. Main problem is between 24 to 33 weeks. In this situation only, if the patient is stable, you can give steroids for the lung maturity, and the magnesium sulfate anyway you are giving. Otherwise, if it is an emergency, you are going to terminate. The other situations like severe pre-eclampsia, eclampsia, help chronic hypertension with a superimposed pre-eclampsia, you have to deliver the patient. Delivery, if it is on labor, go with normal delivery. Otherwise, better to go with the LSES. When if you are going for LSES, epidural and spinal anesthesia, the platelet count should be monitored. Anyway, you have sent the blood. If it is better, more than 80,000, it will be better. General anesthesia, most of the time it is avoided because there will be the laryngeal edema, intubation will be difficult. Again, aspiration, the risk of aspiration is also possible. So better to go with the spinal anesthesia. So this is the way we are going to deliver it. So how will you going to counsel once the patient is going to discharge? The rate of free eclampsia in the next pregnancy is 25%. Rate of eclampsia is 2%. And again, this suppose if it is starting in the 32 weeks, means in the next pregnancy, it can start even in the 28 weeks. So better if it becomes a positive, means to start with the aspirin and other things whichever needed to prevent the complications. And always the aspirin is now we give as 150 milligram. This is the previous recommendations. Now we go with the 150 milligram of aspirin only. So this is the way we are going to diagnose eclampsia, investigate and treat. The prediction, nothing can predict the pre-eclampsia, the mean arterial pressure and all we can try, but it cannot predict a pre-eclampsia. And the rollover test was previously used, but now it is not useful. Again, the markers such as uterine mean arterial pressure, uterine artery Doppler, serum PLGF, and SFLT1. These are the predictors. Nowadays, it is talked more. SFLT by PAG ratio, if elevated, you consider it as a preeclampsia. See, this SFLT by PAGF ratio, you can take in the first trimester and second trimester. If it is less than 38 weeks, means do it every 4 weeks. And if it is between 38 to 88 weeks, follow up after a week. And if it is more than 85 means, you have to terminate. So these are all the predictors, but no predictors can prevent preeclampsia. This is the full Payers model with the gestational age, previous history, platelet count, and LFT, RFT. This can be monitored. The goal of full Payers model is to validate a tool that identifies that with preeclampsia who were prone for developing maternal and the perinatal outcome, whether it will be good or whether it can be prolonged. So this is the full Payers model, and our own model is Gestosys score. When you do this for an hypertensive disorder in pregnancy, you can assess this patient can go for preeclampsia, and if you don't identify the preeclampsia, it can go for eclampsia. So finally, always monitor the BP properly. Sitting position, left lateral position, appropriate cup. Follow up the patient. If the patient is not coming, you have to give a call. Otherwise, she will come and end up with the eclampsia. Control the hypertension and prevent the complications. That is, if it is the preeclampsia, start with magnesium sulfate. And if you don't have the facilities, give the loading dose, stabilize the patient, and refer the patient to the higher centers as early as possible. So that is the reason why we can reduce the mortality due to eclampsia. So I sincere request for all of you to support me for the FOXI president coming year 2026. So this is our adolescents to menopause. We will take into care. And thank you for this opportunity. Yes,
Sujata ma'am. Yes, Sujata ma'am, for your expert opinion, ma'am.
Yeah, it was very, very, very informative lecture, madam. In such a short time, I think you have covered all the aspects of eclampsia very nicely.
Thank you, Dr. Sujata.
Yes, yes. It was very exciting, and all the best, madam, for your future endeavors.
Thank you, Dr. Sujata. If any doubt, you can post in the chat box. We will answer. Then we will go with the panel discussion. Thank you, Dr. Sujata, for joining.
And this will be available online also, madam, in the YouTube, on YouTube. Yeah,
which one? Yes, that link I will put in the group. That will be available in the YouTube also.
Okay. Okay. Thank you. Thank you, madam.
Thank you so much, Sujata ma'am. Esteemed faculty and delegates, kindly request you all to cast your valuable votes for Dr. Sampath Kumari ma'am for the upcoming elections, 2026 FOXI presidential elections. Now moving on to the next session, which is a very interesting panel on PPH, for which we have our expert moderators, Dr. Meena Mahalingam, who is Associate Professor of Obstetric and Gynecology at Chengalpet Medical College. She's now currently the Secretary of OXI, and she's a member of the Urogynecological Committee of FOXI, and she's also received the scholarship from IUGA for attending the IUGA conference in Italy. Our next moderator, we have Dr. Suhasini Karnal, who is a consultant obstetrician, gynecologist, and laparoscopic surgeon. And now currently she's the vice associate professor at Muthukumaran Medical College. And we have our esteemed panelists, Dr. Pratibha Baldawa, who's received a fellowship in infertility and also in laparoscopy, and she's the director of Baldwala Fertility Point and Test Tube Baby Center. And she's a past treasurer and also the past secretary of SOGS and executive member and website coordinator of SOGS. Welcome, ma'am. Next, we have Dr. Jyoti Akala Devi, who's done her DGO from Gandhi Medical College and who's been in government service for more than 22 years and who's from Mancherial. Welcome, ma'am. We have Dr. Tangamani, who's a professor of Department of OG at Chengalpet Medical College, and she's had a teaching experience of more than 20 years for both UG and PG, and she has numerous papers and publications to her credit. We have Dr. Ashwini from Solapur, but Ashwini ma'am is not able to join due to an emergency. And we have Dr. Ketaki Joshi, who's the secretary of Solapur OB-GYN Society. Welcome, ma'am. We have Dr. Swati, who is currently the assistant professor at SMMCH and Research Institute, Chennai, and she has various publications to her credit. Yes. Over to you, Meena ma'am and Suhasini ma'am.
Thank you, Madhumita Arun Karthik, for the introduction. And thank you, Sampath Kumari madam, for having given us the wonderful opportunity to moderate the panel on postpartum hemorrhage. On behalf of the moderators, we would like to thank you, ma'am. Now, we welcome all our panelists. Sahiti, can you project the slides from your side?
Yes, ma'am.
As we all know, the postpartum hemorrhage is a obstetric nightmare. It is important we anticipate and act swiftly. Next. Sahiti. So we know this is a monument of love, but as obstetrician, we should know it is also the symbol of maternal death. And Shah Jahan is built after the death of Mumtaz in her 14th delivery due to PPH. Now we move on with the case scenario without wasting much of the time. We have a 28-year-old woman who's a second gravida, para 1 live 1, who's at 39 weeks plus 2 days. She delivered a male baby of weight 3.3 kg by normal vaginal delivery with no antenatal risk factors. Third stage was managed by active management. 20 minutes after delivery, she develops heavy vaginal bleeding. Initial vital signs were heart rate was 120 beats per minute and blood pressure was 92/56 millimeters of mercury. And her respiratory rate was 24 breaths per minute. Patient was pale, alert, but anxious. Her estimated cumulative blood loss was around 1200 ml and ongoing. Uterus is boggy on palpation. And can we have Tangamani madam to answer about this case? Next slide.
Good evening. First of all, I thank Pinnacle News and OPSI President Dr. Sampath Kumari ma'am and Dr. Meena for giving me this opportunity. So this is a case of bleeding after delivery, vaginal delivery. Heart rate, there is tachycardia and hypotension and pallor. Uterus is not well contracted, and this is a case of atonic PPH.
Madam, can you define what is atonic or the postpartum hemorrhage per se?
Okay, so loss of blood more than 500 ml from genital tract after delivery is called postpartum hemorrhage. And according to ACOG, there is if there is 10% fall in hematocrit indicates PPH, and more than 1000 ml during cesarean section is PPH, and any blood loss significant enough to cause hemodynamic instability is called postpartum hemorrhage.
Thank you, madam. As we all know, so the blood loss, whether it is 500 or 1000 ml following a normal delivery or a cesarean section, is generally called as postpartum hemorrhage. Next slide. Suhasini.
So, the next panelist, what are the common causes of PPH? As we know, there are 4 more common causes of PPH. Can any one of the panelists list out the causes of PPH?
Dr. Pratibha ma'am, Jyoti ma'am, Dr. Ketaki Joshi or Swati.
The common causes of PPH, actually, the atonicity is the most common cause of PPH, ma'am. Followed by this trauma to any genital lacerations during delivery, and also the retained tissue, the placental products during delivery, and thrombin. These are the 4 causes of PPH. Among them, the tone is the most common cause, ma'am.
Thank you, Swati. So, going on to the next slide. Yeah. So here we have got the list of causes of PPH, the pre-existing conditions, and then per se the uterine overdistension caused by polyhydramnios multiple gestation, macrosomia, or prolonged labor more than 12 hours, chorioamnionitis, and tocolytic agents usage, more of tocolytic agents, and more number of deliveries in the past. Then disorders of placenta, uterine, and genital tract trauma also account to the causes of PPH. Can we go to the next slide, please?
So now coming on with the case, what are the early warning signs and how are we going to diagnose PPH? Ashwini ma'am, not there. Dr. Jyoti madam.
Yes, ma'am.
So can you elaborate on the warning signs, madam? What we
Warning
generally
signs, if the vaginal bleeding is either as a trickle soaking one pad in 45 minutes or a copious flow, that is a symptom of diagnostic symptom of PPH. The uterus is enlarged and if it is feels boggy, means boggy and palpation, that means it is filled with blood or blood clot. So that is the those are the symptoms of PPH. And coming to signs, paler in patient when compared to her basic status when she entered before delivery, and tachycardia, hypotension, altered level of consciousness, restlessness, drowsiness, and finally maternal collapse. Those are the signs of PPH, ma'am.
Thank you so much, Jyoti ma'am. Next slide. Next slide.
Next slide.
So already madam has mentioned all the signs of pallor, tachycardia, hypotension. Actually, we need to monitor the postpartum using the modified early obstetric warning score chart, which we call it as the MUOS chart, or we can have a customized chart in our own hospital-based setup. Next slide. Sahiti. Yeah.
So coming on to the next question. So we all know that PPH, the estimation of blood loss is very, very important for us to correct the hypovolemia and treat the patient and save the patient. So how do you estimate the blood loss? Dr. Pratibha, madam? Dr. Jyoti, ma'am?
Ma'am, if any soiled sanitary towel, means that we can take it as 30 ml of blood loss, madam. If the small soaked swab of 10 into 10 centimeters, that comes to 60 ml, ma'am. If not the soiled but soaked sanitary pad, it comes to 100 ml, ma'am. And if the soaked swab, when it is 100 centimeters one, 100 centimeters diaper is sloped and the blood is spilling on the floor, means that is 1500 ml, ma'am. And when the PPH is on the bed only, that is 1000 ml. If it is spilling onto the floor, that is 2000 ml. If it fills the kidney dish, that comes to 500 ml, ma'am.
Yes, ma'am. Thank you, Jyoti, ma'am.
Thank you.
Next slide.
Next slide. So this is a blood loss using a V-drip, which we routinely customize and use it for all our patients. There are two lines. Basically, there is a warning line at 200 ml, and there is an action line which is around 350 ml. Next slide. This is an estimation of blood using the Kelly pad using measuring cup, which is placed at the end of the Kelly pad. Next slide. So can Tangamani madam elaborate on shock index? So shock index is calculated by heart rate divided by systolic blood pressure. This should should be less than 0.5. 0.5 to 0.9 is estimated blood loss is 500 to 750 ml. The total blood loss is less than 20%. The shock index is 1. The blood loss is 1000 to 1500 ml. And if it is more than 1.5, the loss is 1500 to 2500. And more than 2 indicates massive blood loss, that is 2500 to 3500. And the 70% of the 50 to 70% of blood is lost. This is shock index. Thank you so much, madam. So it is important that everyone in our labor ward have to calculate the heart rate and systolic blood pressure. Anything less than 1, we are happy, and anything equal to 1, we just have to take the next action. Next slide. So this is again what madam has elaborated about the systolic blood pressure, the symptoms and signs already explained. So this actually we graded the stages of shock: compensated, mild, moderate, and severe shock. Next slide. Can you just elaborate also on rule of 30, madam? So rule of 30 is the systolic blood pressure falls by 30 millimeter of mercury, and the heart rate rises by 30 beats per minute, and the respiratory rate rises by 30 breaths per minute. And
Next slide. Can you move on? Next slide, Sahiti.
And also we can add when the urine output falls less
Yes,
than
falls
30
less 30 ml per hour, and the hematocrit drops by 30%. So this is the rule of 30. So it is important to remember all 30s in case of postpartum hemorrhage. Next slide.
So now
So
coming to
Hasina,
the case per se. So now we have learned about the basics of all the PPH. Now how we are going to manage this patient? Dr. Pratibha,
Dr.
madam?
Swati. Yeah,
Dr. Swati.
Pratibha, ma'am.
Yes, ma'am. It is a case of actually atonic PPH. So first and foremost thing in obstetric emergencies, we should call for help. Inform our seniors and hands on the uterus, which is we should continue uterine massage until the other drugs are kept ready. And we should find out the cause, whether it is the trauma is the cause or tone or tissue. Here the tone is the reason, so we should start uterotonics. Oxytocin can be given 10 units infusion 500 ml RN, and if at all it is not available, we can go ahead with misoprostol 800,000 microgram per rectally also. And in the meanwhile time, we can find for other drugs like carboprost. Tranexamic acid can be given, and uterine massage to be continued. After this uterotonics also, the bleeding is continued, then the pressure to be given. Tamponade to be is the next step. And if we are shifting to OT, we can shift by putting a non-pneumatic anti-shock garment, so that there will be a dissipation of the blood to the vital organs. After shifting, we can go ahead with if at all the medical management is really failed and tamponade also fails, then we can go ahead with surgical management. Compression suture, conservative surgical managements like compression sutures can be done, and stepwise devascularization. Final is internal iliac artery ligation. If that also fails, we will be proceeding with the subtotal hysterectomy.
Thank you, Dr. Swati. You're given the full management. So
Now,
what about the ergometrin? Methergin, are we using methergin? Can any panelist?
Yes, ma'am. We can use methergin 0.2 mg when oxytocin is when we don't get proper response with oxytocin, but it is contraindicated in hypertension and cardiac diseases, madam, as it contracts the blood vessels and contracts the uterus swiftly. So the blood will be pushed back onto the heart. So that's why it has to be has not to be given in hypertension and cardiac diseases.
Thank you, ma'am.
and what about carboprost and misoprostol?
Carboprost and misoprostol, when oxytocin and ergometrin are failed, then we can go for misoprostol, madam. There are no contraindications, and it has to be given PR 800 to 1000 mcg. It is in low
In low resource setting
low
where
resource
we don't have
centers,
the
it is the most important drug, life-saving drug as such.
Yeah.
Actually, we not refrigerate. Excellent, madam.
Yeah, yes.
And also carboprost, after giving the first dose, we repeat
Yeah.
after second dose. We need to make a decision to shift the patient to theatre as half an hour time is already up. Thank you, madam. And what is the role of your carbitocin rule? Are you using it regularly, madam?
Which one, madam?
Carbitocin.
Carbitocin we are using as a preventive measure for multiparity patients, madam.
Okay.
As a preventive measure.
Thank you, madam. Next slide. So what is the role of tranexamic acid, madam?
So it helps to reduce bleeding, and the dose is 1 gram IV over 10 minutes. And we can repeat the dose after 30 to 45 minutes if bleeding continues. So it reduces the mortality due to PPH by 30%.
Okay, again there is a 30%. Thank you, madam. So you can repeat the dose after 30 minutes as madam told. So,
So within
as it
3 hours,
prevents
it has to be
the
given. What do you
premature
want?
fibrin network, so it is very useful, madam. Tranexamic acid as such. Okay. Do you
Yes, ma'am.
routinely use in your setup, madam? Madam? You are using routinely tranexamic acid in your setup? Not routinely, madam. When we anticipate, then only. Okay. Actually, in our setup, tranexamic acid, we keep it ready, and we do not keep it in the theater if you are doing a cesarean section. Basically, we have a confusion with bupivacaine. So, if there is a need, usually we get the tranexamic acid injection from the labor ward and bring it to the theater, basically. Yes, so Hasni, thank you, Jyoti ma'am. Ma'am, can I have ask a question, madam? Yes. Among tranexamic acid and misoprostol, like in our setup, I am dependent on misoprostol, and I have good results also. What do you say, ma'am? Yes, madam. In a setting where we're not having a refrigeration, we still go on adding misoprostol to our armamentarium because it is very useful. We keep it pervaginally or perrectally or give it sublingually as well, madam. It really works for us. But as a tertiary center, we keep tranexamic acid also ready. Okay, madam. Okay. Yeah, thank you. So, Asni?
So now we have done all the medical management, and if still the bleeding is continuing after the uterotonics and tranexamic acid, so what will be the next step?
Dr. Joshi, ma'am.
Joshi.
Pratibha, madam. Dr. Pratibha, ma'am. Dr. Joshi, ma'am. Swati.
We can give a bimanual compression, ma'am. Uterine compression can be given by one person. The other person can keep the intrauterine tamponade ready. Usually, we all are this thing have condoms. We can prepare a condom catheter. 500 ml can be instilled, and the pressure can be maintained so that we can watch whether the bleeding is controlled or not, ma'am.
Thank you.
And
do you use NASG suit in your setting, madam? NASG suit?
Ma'am, actually, in our hospital, as such, now we don't have this suit. We have requested the higher authorities for the same, ma'am.
In our government sector, we do have this NASG suit being distributed to all the urban primary health centers, wherein they apply the suit during transport through 108 ambulance to our tertiary center. So we are using it as a transport system, and once the patient reaches our tertiary center, we do take the patient to theater and do exploration of the episiotomy or a traumatic PPH in theater without removing the suit. And if there is a need for a laparotomy, we just remove the last pieces of the suit and then do a laparotomy. Thank you, madam. About SR cannon.
1 minute, Meena. Sugasini, there is a doubt in question box. Tranexamic acid, will you dilute in 100 ml or 500 ml normal saline?
100 ml we can dilute, ma'am. 1 gram in 100 ml.
100 ml is enough, I think.
Enough.
Yeah. Madam, really NSG suit, if you have at primary healthcare centers also means it makes a lot of difference, madam. Really, you are blessed to have that that periphery. Our government, they have provided the NASG suit to all the tertiary centers, the DMS sector and the DPH sector. It is very useful in mainly the transport. There are studies in Egypt where they have made transport and kept it for around 45 hours. We generally, once the patient settles, we generally remove the suit slowly, gradually, madam. We are using it. It makes a lot of difference, madam. Even by seeing the slide also, we are able to understand. Yes, ma'am. Yeah. Suhasini?
Yes, ma'am. Any of the panelists have experience with using SR cannula?
No, madam, I don't have any experience.
Swati?
Actually, SR cannula is easily applicable even by our juniors, ma'am, if at all it is taught properly. And if the set is available with the proper vacuum apparatus, we can very well gain the time of the next step of the management as the uterus gets contracted and retracted due to the vacuum negative pressure.
Yeah, so generally in the government sector, we are being supplied with both the SR cannula, which can be introduced through the cervix for normal deliveries, and intrauterine placement when we are doing a cesarean section is also being done. It is really helping us, and also we are able to monitor the blood loss, which is easily monitored because we are able to connect the suction tip along with the SR cannula. And once we monitor, if there is no loss, we usually remove it after 12 to 24 hours. And about intrauterine tamponade, anybody wants to say, madam, your experience?
I think already they have told me, ma'am.
So
in
in the
Madam,
government sector,
can you explain more about SR cannula during cesarean section, madam?
yes. Next slide. Next slide. We actually have a video, but I'm not loaded in this. This is about the balloon Follies. Next slide. This is a Bakri balloon. We have Cook's catheter, Sengstake and Blackmore tube. Next slide. This is the aortic compression. We place our fist onto the right side of the umbilicus, usually to compress more towards the left side because IVC is on the right side. We place more towards the left side of the patient, just on the left side of the umbilicus. Next slide. This is the NASG suit. Ma'am, I'll show the PPH suction cannula in the next slide. The next slide. This is the NASG suit, which has got numbers. This is the SR cannula, which we have in our hospital, madam. The first tray contains different sizes, which we can introduce from the vaginal end. And the second is about the suction machine. We generally use the suction machine, which we are using for the vacuum delivery. And this is the connecting suction tube. So we usually introduce it to the cervix after holding the anterior lip of the cervix with the sponge holder. After introducing, we generally press on the suction and create a suction of around vacuum suction of around 600 millimeters of mercury. Once the suction is created, usually it causes a negative. Next slide. So this is how it acts, madam. This the suction cannula, which is placed inside the relaxed atonic uterus. Once the suction apparatus is switched on, the uterine cavity gets sucked into these perforated areas, and once it is done, the uterus gets contracted and retracted on the surface of the cannula. This mainly assists the natural physiological process of contraction and retraction. Once we can see all the perforators are just above the cervix.
Yes,
once the bleeding is stopped, we usually insert one of a tip of the fingers into the cervix and we release the vacuum which is holding the uterine cavity. Once it is released, the entire suction cannula can be removed, madam. That is how we do. Sometimes we have had difficulties in removing the SR cannula. In that case, we have introduced a small artery forceps and release the uterine cavity, that is the endometrial surface, thereby releasing the entire vacuum and releasing the suction cannula. Hope I am clear, Jyoti ma'am.
Yeah, it's clear, madam. But in cesarean sections also, can we use this?
In cesarean section, what we do is we connect the suction tip and then we introduce the cannula into the uterine cavity. Before that, the suction cannula is brought out through the cervical os. And once we have started closing the uterine cavity, we start keeping the negative pressure and the whole entire uterine cavity gets sucked. And it creates a cricket ball consistency after placing inside the abdominal cavity, we'll be able to appreciate the well contracted uterus. And like our Foley's balloon, we generally bring out the suction cannula connected suction tip to the vacuum machine. That is how it works, madam. If there is a fresh bleeding, we generally reassess and then plan for the next step.
Okay, madam. Thank you.
Thank you. Maybe I can share a video in this group, madam.
Okay, thank you, madam. Thank you.
Thank you, madam.
So now after the conservative measures, still the patient is continuing to bleed. So what will be our next step? Like uterine sparing surgical options?
We can go ahead with compression sutures, ma'am. The first thing, we use a B-line suture during cesarean section because the uterine insertion will be there. We take a 3 centimeter below that uterine insertion, that 2 centimeter lateral to the 2 centimeter lateral to the surface, from anterior to posterior, covering the fundus. That vertical compression sutures can be taken. And Heyman sutures is used when we are not doing sections. We are shifting for the case of normal deliveries for PPH. Then vertical compression sutures, Heyman, can be done in a similar way. This Cho sutures is used for local, like focal bleeding in the areas. Then Cho sutures, it's a square type of sutures which can be used. These are the sparing procedures. If at all it is failed, then we can go ahead with stepwise vascular devascularization, starting with single uterine artery. Then both of the bilateral uterine artery ligation can be done. Next to which utero-ovarian, this anastomosis there, we can ligate. Finally, we can go ahead with internal iliac artery ligation. But in between itself, bleeding is arrested, then we can stop in the same step. It's not that we should complete all the 3 artery ligation. If it is failure of internal iliac artery ligation also, then we can go ahead with subtotal hysterectomy, ma'am.
Yeah. So hysterectomy should be done earlier rather than later, and it should be decided by 2 consultants. Generally, if it is a PPH, we can plan for a subtotal hysterectomy, and if the PPH is due to placenta accreta or if there is a placenta previa, it is better to go for a total hysterectomy, which will be life-saving. Always it is important to remember, removing the uterus and making the women live is important than leaving the uterus and leaving the women dead. Thank you. Next. Can Tangamani madam elaborate on the compression suture a little more? So as Swati has already demonstrated, so just this should be placed in all the labor wards. So we have a laminated picture of compression sutures of B-Lynch, and also we do train the postgraduates to do a B-Lynch suture on the hysterectomized specimen so that they have a feel of the B-Lynch suture. And mainly the B-Lynch suture is made, once the suture is made, it is important to ask the assistant to hold compressing the anterior surface of the uterus to the posterior surface and bending the uterus so that the upper segment compresses the lower segment. That is the picture shown in the last diagram. Next slide. So this already been told. Heyman suture is done once the woman has delivered by labor natural, and we are shifting her to theatre for laparotomy, Heyman suture. And Swati has clearly explained about Cho suture. And we also have Gunashila's Global Stitch, who's from Bangalore. We do complete suturing as a Gunashila's Global Stitch. Next slide. Sahiti. So this also been explained like the stepwise pelvic devascularization. Next slide. So internal iliac artery ligation generally reduces the pulse pressure, thereby decreases the vascularity in the uterine vessels. Next slide. So already done. Next slide. So the steps, pulse pressure is reduced by 85 and the mean arterial pressure reduces by 25 to 50%, reducing the blood flow by 50%, and ligation abolishes the trip hammer effect of arterial pulsation. This promotes clot formation, thereby converting the arterial system into a venous system, promoting stable clot formation. Next slide. Suhasini.
So what is the role of interventional radiology, and what are the options available?
Jyoti ma'am.
It is uterine artery embolization is the option available, madam, as per interventional radiology when other methods fail.
So generally it is done in the radiology department. We do actually put a balloon or put some polyvinyl particles or a gel foam, and we inject it through the femoral artery route and go negotiate. Femoral will go through the external iliac and then go to the common iliac and then go to the, it's actually taking a bend and coming through the internal iliac artery and the uterine artery, and then we have to explain her. And nowadays, we do have interventional radiologists helping us even before we plan and do a placenta accreta as well. Once the baby is delivered, they inflate the balloon to reduce the vascularity through the uterine artery. Next slide. So, can Madam Tangamani Madam elaborate on complications of postpartum hemorrhage?
Okay. PPH leads to anemia, and the most dangerous complication of postpartum hemorrhage is irreversible hypovolemic shock, leading to myocardial ischemia, dilutional coagulopathy, and finally, maternal mortality is the important complication of uncontrolled PPH. Then renal failure, blood transfusion reactions, depression, and late complication is Sheehan syndrome, leads to failure of lactation, secondary amenorrhea, breast atrophy, and superinvolution of uterus, hypothyroidism, and adrenal cortical insufficiency. These are late complications, but the important complication is irreversible hypovolemic shock leading to maternal mortality.
Thank you, Madam. Suhasini?
Next
Sahiti,
slide.
next slide. Sahiti? Next slide, please.
So I'll just go with the question. Meanwhile, you can change the slide also. So what are the, can PPH be prevented? If so, what are the preventive strategies to prevent PPH?
So proper antenatal care. So identify anemia, correct anemia, diagnose anemia and treat anemia before third trimester and before delivery. And I do ultrasound and rule out placenta previa, and always advise 100% institutional delivery and skilled attendance at birth, and community awareness, behavior change communication with IEC materials, and the complications of large baby, over distended uterus, and previous history of PPH and placenta previa spectrum disease, all should be delivered at 37 completed weeks of gestation, and all termination of pregnancy should be done in the morning hours where everyone are available and with adequate blood.
Next slide.
Okay.
Next slide. Suhasini, you want to add on?
We all should have keep regular PPH drills with our staffs, and we should make them aware of how, if a PPH comes, how they have to act very in a short time, very actively. They have to control the bleeding. Regular drills have to be conducted, and we have to be more vigilant. That is what is very important. In the antenatal period, when we identify the risk factors, to some extent we can prevent. On table, when we identify a PPH, you see the visual estimation, then acting swiftly is what is very, very important here. And of course, active management of third stage labor. That is also very, very important, which reduces the PPH.
Next slide. So this is something we attach in our routine case sheets, Lakshya case sheets, which says about low, medium, and high risk. So one more thing, it is not a risk-based management, because even low risk women can have a postpartum hemorrhage, but we do have this attached in our case sheets and do have a tick mark, the tick box phenomena, like placenta previa, low lying placenta accreta has a high risk for PPH, and medium risk whenever there is a multiple gestation or hydramnios, and high order birth like multiparity, grand multi. We have had a delivery of 9th gravida, be photomania, recently delivered, and the low risk means singleton without any risk factors. Next slide. So can Thangamani madam elaborate on active management of third stage of labor?
So active management of third stage of labor significantly reduce the incidence of postpartum hemorrhage. So each and every delivering woman should receive active management of third stage of labor during a normal delivery and also during cesarean section. So it consists of 3 steps. First one, immediately after delivery of the baby, within 1 minute, oxytocin 10 units is given intramuscularly. And the second step is controlled cord traction and stabilizing the uterus by applying a counter traction. And third step is uterine massage after delivery of the placenta. So can significantly prevent PPH.
So this was the initial teaching, as madam has already rightly told. The injection oxytocin is given only after confirming there is no twins, and the massage is not routinely followed nowadays, according to the latest figure, which we'll be going through the next slides. Next slide. So this is the obstetric warning chart which I was talking about. Next slide. Suhasini.
Yeah. So we'll go on to the next case scenario. She's a 26-year-old Mrs. X. She's delivered now, referred from a private hospital with complaints of bleeding per vaginum since delivery. So she's delivered and she's now bleeding. And she was medically managed with the uterotonics, as we have discussed like previously. They have used all the uterotonics. Fluids were given and 1 unit of PRBC was also transfused. Still bleeding is persistent. Now she's coming to you from a private hospital. So what will be your further management?
Jyoti madam, how you would have managed this case?
Now, madam, already she has been managed in a private hospital. When she come to our hospital, we should shift her to HDU, and 2 IV lines, whether we should see 2 IV lines are secured or not. Whether not secured, we have to secure, and blood for cross matching has to be taken. No need of blood for blood for cross matching has to be taken, and bladder has to be catheterized. The routine investigations to be sent, and PRBC transfusion and flow already is there. So bedside, we don't know the cause. As of now, we don't know the cause because they have given already uterotonics. They have given a transfusion. Now we have to see the second, second one, that is any tissue is there inside. So we have to do bedside ultrasound for normal uterine contour to rule out any broad ligament hematoma inside due to any abnormality in the delivery or any RPOC. So any free fluid. For that, we have to do bedside ultrasound and 2 units of PRBC and 1 unit of normal saline has to rush according to our vitals, and patient will be shifted to UOT, and vaginal exploration has to be done under anesthesia.
So we have to keep in mind,
madam,
we have to keep in mind when you do an ultrasound and find out the normal uterine content.
If we find any tissue or RPOC, we have to shift her to the OT and we have to clear it out. And
so in this patient, the ultrasound was done and there was no RPOC, no free fluid in the pelvis and abdomen, so and a normal uterine contour. So what will be our next step?
Next step, then we have to go see the genital tract, any trauma.
So we have to rule out traumatic PPH.
Traumatic PPH, any cervical lacerations, vaginal tears, any hematoma inside. So we have to rule out genital tract cause.
Yes, ma'am. So we have to better shift to OT and give a nice exploration should be there. Nice lighting should be there. So
yes.
exploration needs good lighting. So better to do it under OT, not in the labor ward, under anesthesia preferably, and look for any traumatic trauma in the vagina or the cervix. Yeah. So in this patient, we have identified a laceration in the vagina above the apex. So we have identified the defect and then it was sutured. So hemostasis were achieved. So intraoperatively, 2 units of PRBC were given and 8 units of FFP, 4 platelets, 4 cryoprecipitate, and injection syntocinon 20 units in 500 ml of RL was given. And post-op also 2 units of FFP and 4 units of cryoprecipitate. So here, why have we given so much?
Madam, according to the patient's general condition and the loss of with the severe PPH, we will have the dilutional coagulopathy also.
Yes,
So
ma'am.
we
She has
need to
gone
replace.
for DIC. Yeah. So she has gone for coagulopathy. So we have initiated the massive transfusion protocol here.
Yes, ma'am.
Next slide, please.
So when do we initiate a massive transfusion protocol, and what is the ratio in which it is given, Swati?
Massive transfusion protocol can be initiated in such cases where there is continuous bleeding, ma'am, in spite of replacing PRBCs. In 1 hour, almost 4 PRBCs have been replaced, and still the vitals are like hypotension and tachycardia is there, and medical management ultrasonics and Renex have been failed. Then we can call for massive transfusion protocol. It is given in the ratio of 1:1:1, which is like PRBC is to FFP and platelets. And in the meanwhile time, we should check for the fibrinogen value, because it is one of the earliest indicator to fall before even the coagulopathy starts. So fibrinogen should be measured, and if at all it is less than 300, then it is the criteria to announce for massive transfusion protocol.
Next slide. So this is a 27 years old, second gravida, previous normal, and previous LSCS. It was a LCB 1 year, 17 weeks. Admitted with complaints of spotting per vaginum, ultrasound, there was a low-lying placenta, patient treated conservatively. After 4 days, patient complained of pain and bleeding, followed by spontaneous expulsion of fetus and placenta in bits, and bleeding per vaginum continues. Next slide. So what can we do to this patient?
It looks like incomplete, complete expulsion of fetus, and placental bits are retaining, causing bleeding. So we should establish 2 IV lines, and we should give oxytocin and tranexamic acid and methotrexate, and we should do quick ultrasound pelvis and look for any retained bits. If there are retained bits of placenta under anesthesia, we should try to remove the bits.
Yeah. So, Madam rightly told, we are supposed to give the oxytocin, tranexamic acid, carboprosten, methogen, and methotrexate role is not there in these cases. Generally, if there is active bleeding and we have tried to remove from below, and if it doesn't help, in this case, as the patient was deteriorating, her pulse was raising and the BP was falling, we had to immediately shift the patient to theatre with ultrasound guidance. We couldn't remove, and it was placenta accreta spectrum. So we proceeded to laparotomy, and we had to do a hysterectomy to save the life of the women. And the patient was in GA, and we had kept an intraperitoneal drain and also a subcutaneous drain. And intraop loss was around 800 ml. Blood and blood products were transfused. Next slide.
Madam, only the gestation age is 17 weeks. And
Yeah. This case I am just presenting here because we think low-lying placenta is usually after 28 weeks, 32 weeks. This case, it was really a nightmare because the patient started pouring after delivery of the placenta in bits. And once we have shifted to theatre because the general condition was deteriorating, we couldn't manage the blood loss from below. We had to open up, and after sending the uterus, we found that the specimen came as placenta accreta spectrum. This case I'm just presenting here because it is a rare presentation. We think it can happen only in later gestation. It is not so, madam.
Madam, at my setup once I encountered one case. It was just a 17 weeks gestation age, and she was anemic, and I previous to mid trimester abortions because of pa- uh, because the surplus was not done in previous cases. So I wanted to go for surplus this time because of the short cervix. So as she had anemia, I have given blood transfusion. After transfusion, she spontaneously aborted the fetus, and I encountered with PPH. I didn't understand the reason there, madam.
Yeah, because we are not able to sometimes find out. We have to think in terms of other things as well, madam. We generally think of tone. Sometimes the tissue also could be a reason. There was one more case wherein the delivery had happened at around 2:30 in the afternoon, and the patient had a heavy pour of bleeding. They tried to do all the as in the previous case, we were trying to see for the traumatic cause, as there was good tone, like a cricket ball consistency, and we tried suturing as well. Then later, since there was heavy bleeding and the patient's condition was deteriorating, we shifted her to next center, and then on doing evaluation in the theater, in the laparotomy, we could see there was a big placental chunk inside, and the ultrasound did not pick up. That could be a succinsurate lobe as well, which was missed. And, then we could save the uterus because we did an internal artery ligation and kept a Foley balloon. Patient revived and survived with the uterus in situ. As in your case, you were telling about previous two miscarriages. This case was a second gravida and a previous miscarriage, madam. Anything can be there. Surprise can happen on table as well.
And can we suspect any thrombin deficiency in such patients, madam?
Thrombin deficiency, usually we would have had a previous history from the younger age having a menorrhagia or a epistaxis or any other bleeding disorder, madam.
Okay.
Usually we can pick up based on the previous history, madam.
Okay, madam.
Thank you.
Thank you, madam. Thank
So, Hasni?
So we'll move on to the last case scenario. She's Mrs. G, 27-year-old, presents on day 12 of postpartum with excessive vaginal bleeding and foul-smelling vaginal discharge. She had a spontaneous vaginal delivery at home. So on examination, patient was pale and the pulse rate was 98 per minute, BP 160. Uterus is 14 week size, so it is subinvoluted, and it was mildly tender. On speculum examination, there was foul-smelling discharge and bleeding was moderate. Her hemoglobin showed 8.9 and ultrasound showed retain echogenic material in the cavity. So how are we going to manage this patient?
So this
What's
is
the
a
diagnosis?
case of secondary PPH due to retained bits of placenta. So first we have to take vaginal swab for culture sensitivity and blood for culture and sensitivity. Then we have to start higher antibiotics, including metronidazole. And for we have to do CRP and total count, and we have to correct anemia, and if possible, under ultrasound guidance after antibiotic coverage, we can try to remove the bits.
Yes, ma'am.
Yeah.
Thank you, ma'am.
So the main thing is the FIGO recommendations. 2025, they have come up with the recommendation for postpartum hemorrhage.
1 minute. I want to say this mostly secondary PPH are due to retained bits, adherent placenta, and second one is AV malformations. So we have to diagnose the AV malformation by MRI. If it is AV malformation, uterine artery embolization is best. And if it is adherent placenta, the parity is completed, we should do hysterectomy. Thank you.
Thank you. So that's a very good point, madam. AV fistulas are quite common, and the arteriovenous malformations. Generally, we have seen such cases in the gynec patients, and where we have done a uterine artery embolization. In the antenatal patient, we have not seen. That is one of the important causes which also can lead to a PPH. And FIGO recommendations states early detection and measurement move from visual estimates to objective measurement, like weighing the swab, drain, and also using the V drapes for faster accurate diagnosis, defining PPH as 500 ml blood loss or signs of shock. And also about the care bundle, first line is massage, which is a continuous for treatment. A nutrotonic oxytocin IV or IM is preferred. Heat stable carbetocin if cold chain is unreliable. And as Jyoti madam was telling, even misoprostol is better. And tranexamic acid, early IV administration within 3 hours. And IV fluid oxygen. Examine for trauma, retain tissue, and active management of third stage of labor, which has been mentioned by Dr. Tangamani madam. And always keep oxytocin as the first line. And resource limited settings, we can go for misoprostol and also the drugs which requires less storage. So it is important, as Suhasini was rightly telling, training all the providers, nurses, midwives, doctors, having a PPH drill, even when there is no case of PPH, just making a scenario as PPH and managing really helps to increase the infrastructure. Thank you. Next.
So this is a E-motive trial where E stands for early detection and trigger criteria, and M for massage of the uterus, O for oxytocin drugs like oxytocin and misoprostol and tranexamic acid, T for tranexamic acid, IV for IV fluids, and E for examination and escalation. This is stepwise how you're going to manage a PPH. Next slide, please.
So we would be concluding, PPH remains the leading cause of preventable maternal mortality worldwide. As we know, it is 25 to 30% of maternal deaths, particularly in low resource settings. So timely recognition, structured stepwise management, using standardized protocols, which we can stick in our labor wards, can dramatically reduce the morbidity and mortality. And the MDT team, we should call for help. The senior obstetrician, senior anesthetist, and the midwife, the nurse, the blood bank, and the critical care is very important for getting a successful outcome. And simulation based drills and readiness checklists improve the real time response and outcomes. Next slide.
So the next one is we should anticipate PPH. As we have gone through all the slides, risk strategy, identify the high risk factors when the patient comes for each and every antenatal visits. You have to act early. You can't wait for the patient to go into shock. That's what the WHO recommends. Even at 300 ml, if the patient is showing signs of hypovolemic shock like tachycardia or hypotension, you don't wait for the 500 ml to be lost. You can act that time itself. And also follow the 4 T's systematically. Stepwise protocol-driven management will save lives. We have to administer tranexamic acid early because if you administer tranexamic acid within 3 hours, it works wonder. And availability of blood and blood products is very, very important. Every patient, even if it is without any high risk factor, better to reserve blood. And because we don't know which patient will land up in PPH. And also prevent PPH, always make sure after the delivery of the placenta, the uterine cavity is empty, no retained products or bits. And then teamwork, finally, teamwork, training, and timely intervention. The triad works wonders and it determines the survival of the mother. So we have to act swiftly, and that will save the life of a mother.
So it is important we save mothers, stop PPH, and reduce the maternal mortality. And zero maternal mortality is the aim to have a good sustainable development goal in the near future. We thank myself and Suhasini. We thank our dear panelists, Dr. Tangamani ma'am, Dr. Jyoti, and Dr. Swati, and Dr. Sampath Kumari madam for having given us the wonderful opportunity, and Dr. Madhumita Arun Karthik and Dr. Radhika Gauri for having coordinated the session, and Sahiti Priya for having shared us the slides and giving a wonderful platform. Over to you, ma'am.
Anyway, fantastic panel, Meena. You have done the vote of thanks also. So that officially also it is done. Fantastic PPH panel. Where if more panelists are there, that can be many interesting. I don't know why the panelists are not joining. Anyway, good. Thank you, Suhasini and Meena.
Thank you so much, madam.
Anyway, Madhumita, Irkya? So Madhumita is not there, I think. So we will go with the official vote of thanks. 1 minute. So I thank the president and the secretaries of
Mancheral.
1 minute. Mancherial, Kolhapur, Jalgaon, Aiswal and Solapur. So the president and secretary of all the societies and the wonderful panel chair by Dr. Meena Mahalingam and Swahasini Karnal, and the panelists Swati, Jyoti, and Tangamani Madam, Ketke and Ashwini Pratibha were not able to join, I think, and Dr. Sujata for chairing the eclampsia talk. And I thank all the faculties and the delegates. I think Dr. Kumudini has joined from Darbhanga. All the Pinnacle series, I can see her name in the participant. Anyway, thank you, Dr. Kumudini, and all the Sakiti and Sripriya. Thank you for the coordination.
Thank you, ma'am. Got stuck, ma'am. Is it?
Thank